Welcome everybody. As you may know, we're here today to discuss multiple sclerosis, or MS for short. My name is Dr. Dee, like I mentioned, and I'm here from the Inflammatory Centre of the Brainstem. It's very important that we're here today to talk about MS, since it's currently one of the most common neurological disease. Most of you might be from neuro wards or not bit about MS, so just take this as a refresher on maybe learn something new. Make sure you please sign off your attendance here before we start today. So what we're going to look at today is we're going to run through a little video which looks at a patient journey. We're going to look at signs and symptoms, we're going to look at treatment options, patient management, and finally go to diagnostics tools. After the video, we're just going to explore a few concepts a bit further and then maybe do a quick quiz at the end. So let's get started. Peggy Smith, come follow me.
Hi, I'm Dr. Sclerosis.
Hi, Peggy Smith.
Have a seat. So how are you today?
I'm okay.
That's good to hear. Now what can I do for you?
I've been a bit worried lately because I've been a bit tired and my leg is causing me a bit of pain and it's feeling quite weak lately.
Okay.
Yeah.
Can I have you walk? Let's see how you
Sure.
are. I can see a difference between your legs.
Yeah, this one feels very weak.
Multiple sclerosis, or MS for short, is a neurological disease. It is an autoimmune disorder that afflicts the central nervous system, that is, the brain, spinal cord, and optic nerves. MS can be described as a type 4 hypersensitivity reaction, meaning it is cell-mediated. Mature B cells, otherwise known as plasma cells, produce antibodies, also called immunoglobulins. Autoantibodies are antibodies that target self-antigens. Cytotoxic T cells, sometimes called killer T cells, are a subset of T cells that attack antigenic cells. Oligodendrocytes are cells in the brain with arms that wrap around nerve cells. They form a fatty membrane called a myelin sheath, which insulates and protects the neuron. Cytotoxic T cells attack the cells of the CNS and helper T cells activate macrophages, which target myelin and oligodendrocytes. Damaged areas also develop scar tissue, which are called lesions, plaque, or sclera. This is how the disease gets its name: multiple areas of scarring. Therefore, signs of MS include scarring, elevated inflammatory markers, and phagocytosis, that is, the presence of elevated lymphocytes in the cerebral spinal fluid. What exactly causes MS is not known, but genetics and environmental factors are thought to play a part. Nerves are how the brain communicates to itself and the body. Myelin insulates nerve cells and plays an important role in nerve signaling. Therefore, nerve signals cannot function correctly in MS when the myelin is damaged, leading to a large number of possible symptoms. These symptoms are determined and explained by the location of a damage within the CNS. For example, damage to the optic nerve would lead to visual problems such as blurred or doubled vision. Damage in these places can cause information to become altered or stopped completely. Therefore, there are a range of symptoms that can be expressed and experienced. Common symptoms include fatigue, weakness, impaired sensation, bladder and bowel dysfunction, sight impairment, cognitive impairment, central pain, and neurological attacks. There are also 4 phenotypes, which are given to describe the onset, severity, and occurrence of signs and symptoms. The phenotypes are based on the patterns of symptoms over time. Relapsing remitting MS, or RRMS for short, is the most common form of MS. These are moments of immune responses where inflammation occurs and macrophages target oligodendrocytes. Inflammation is driven by T and B cells. Regulatory T cells suppress the immune response, and oligodendrocytes recover a bit and can remyelinate. This is the remission. Symptoms can improve if remyelination occurs. This process repeats itself where the immune attack comes in waves. This is relapsing. A relapse can also be referred to as a flare-up or an attack. After a while, the damage is too much for oligodendrocytes and the damage becomes permanent. Symptoms come and go. Symptoms tend to be different each time they come back. Each attack leaves the person more disabled than the last. However, there is no further deterioration between the attacks, only during and after an attack. Secondary progressive MS, or SPMS for short, is similar to RRMS, but over time, the immune attack becomes constant rather than periods of remission. Primary progressive MS, or PPMS, is that the immune attack is constant from the start. There is a gradual and ongoing loss of function without distinct attacks. Progressive relapsing MS, or PRMS, is constant immune responses with attacks.
I'll send you off for some blood tests and an MRI, and in a couple of weeks we can set a date to assess the results and discuss what can be further from there.
Okay, sounds good.
The 3 tools used for diagnosing MS include an MRI, a cerebral spinal fluid examination, and an evoked potential examination. A combination of these tests allow for the most accurate diagnosis. An MRI is often performed in order to diagnose MS. Each time a patient has an attack, a lesion forms in the central nervous system due to the inflammation and tissue breakdown. An MRI scans the brain and spinal cord in order to locate where lesions are, the number of lesions, and the size. A scan would reveal one or multiple white spots in the brain or the spinal cord, as small as 3 millimeters in diameter if the patient has MS. However, an MRI cannot decipher the cause of a lesion, and many patients have non-specific lesions on the brain from things such as chronic migraines. This can lead to false positive results. For this reason, MRIs cannot be a diagnostic test alone. Further investigation of a patient's history or testing, such as cerebral spinal fluid examination and signs of MS attack, is required. An MRI is preferred over a CT scan, as the lesions are easier to detect on an MRI, particularly in spaces such as the brainstem, spinal cord, and cerebellum. Doctors are also able to perform a lumbar puncture to gain a sample of the cerebral spinal fluid from the spine. This fluid is then tested for the presence of oligoclonal bands, or OBs, a strong indicator for a diagnosis of MS. OBs are multiple antibodies forming together to create a visible band. These are not normally present in the cerebral spinal fluid. The immune system is not typically functioning in the central nervous system. However, as MS is an autoimmune disease, antibodies will be present in the cerebral spinal fluid. These antibodies are what attack the myelin, as they are able to cross the blood-brain barrier. However, the test can be uncomfortable for patients and must be used in conjunction with other testing. A further test commonly performed is an evoked potential examination. Evoked potentials are generated in the central nervous system by exterior stimulation, causing an electrical event. This examination can test for abnormal function in the central nervous system caused by damaged myelin. Evoked potentials are also used to assist in locating a lesion, particularly when it's in a place that is difficult to see on imaging, for example the optic nerve or sections of the spinal cord. 3 forms of evoked potential tests, however this in-service will look at the most common one, visual evoked potential tests. This is where a patient watches a screen with a checkered board whilst the colours switch. The electrodes on the head test the electrical activity in the brain. It assesses the length of time the electrical signal takes to return to the central nervous system. If it is slower than average, this means that the myelin is likely damaged, as myelin is responsible for fast neuron transmission. Therefore, a patient with a slower test result and damaged myelin is likely to have a diagnosis of MS. On this test, the left eye has a delay, meaning that the myelin of the optic nerve is damaged, showing a slower response. A combination of an MRI scan, cerebral spinal fluid examination, and evoked potential examination can lead to an accurate diagnosis of MS.
Welcome back, Vicky.
Hi.
Have a seat.
Thanks.
I'm just going to pull up your results.
Okay.
How have you been?
Mostly the same kind of symptoms. Yeah, not going to be worse or better.
Well, your results came in. Your blood results show elevated levels of inflammatory marks, signifying your immune system is reacting to something.
Oh, okay.
Your MRI showed some scar tissue in your cerebral cortex. This is an area of your brain which controls your voluntary movement. I can't be certain at this point in time. I shall send off some requests for your imaging and specific tests. I'm going to have to ask for more brain MRIs and a couple of lumbar punctures to pinpoint exactly where this is going on in the brain. It seems like the source of the problem.
Okay, so do you think I'm going to be okay?
Look, there does not seem to be signs of previous damage that we can't be sure of. It's related to what you're experiencing right now. We're going to have to wait and see.
Okay. Thank you.
So we got your results after looking at it. Well, there really isn't any easy way to say this, but you have multiple sclerosis.
What does that mean? Am I going to die?
No, you're not going to die. You're just going to have it for the rest of your life.
Oh, okay.
Yeah. In short, there is no cure, but there are many treatment options available for you. With the treatment options, we aim to minimize the impact of the symptoms, allow you to perform your daily tasks, and slow progression of disease. You'll continue to experience these symptoms, however, and you may also develop new symptoms further down the track.
The primary treatment of MS is through means of disease-modifying therapy, the focus of which is to interfere with the immune system's ability to attack the nerves, and by extension delaying the progression of the disease and symptom manifestations. Interferons are first identified for their antivirulent properties and tested as a possible treatment for MS due to a possibility of a viral link to the pathogenesis of the disease. An interferon beta compound was first identified in the 1980s as an effective treatment for MS due to its autoimmunomodulating effects on the animal model of the MS and autoimmune encephalomyelitis, and compounds later recognized as cytokines. Interferon beta binds to receptors expressed on all cells, with each receptor made up of 2 domains, one required for binding and the other one required for signaling. An intracellular response is then activated when interactions with interferon and the cell occur through the 2 aforementioned receptor domains. The exact role of interferon beta is unknown, though it is known to have immunomodulating effects due to its regulation of T cell and lymphocytes through means of inhibition of T cell activation, T cell apoptosis, and decreased blood-brain barrier permeability. Interferon beta comes in two preparations, interferon beta 1A and interferon beta 1B. Interferon beta 1A is a compound of interferon beta produced by mammalian cells of hamsters, similar to the interferon found in the human body, whereas interferon beta 1B is a protein synthesized by Escherichia coli bacteria, otherwise known as E. coli. Interferon beta treatment options include interferon beta 1A Avenix, which is delivered intramuscularly at 30 micrograms once weekly. Rebif is another compound of interferon beta 1A, which is delivered subcutaneously at 44 micrograms 3 times weekly. Betaseron and Xtavia are interferon beta 1B medications, which is delivered subcutaneously at 0.25 micrograms every other day. All interferon beta medications have been found to have a 30% reduction in MS relapse rates, and also present with similar risks and adverse effects, including flu-like side effects, depression, headaches, liver enzyme abnormalities, injection site pains, fatigue, and allergic reactions. Relevant assessments for all medications include periodically performing complete blood counts and liver function tests. During relapse periods of MS, acute exacerbations of MS symptoms may occur. Medications such as corticosteroids may be administered to provide rapid clinical response by preventing the inflammatory cascade characterized in MS immune response attacks to nerve tissue. Corticosteroids are potent anti-inflammatory agents that express their anti-inflammatory action through a non-genomic interaction with T cells, the main orchestrators of an inflammatory response. Corticosteroids inhibit the migration of inflammatory cells into the CNS by means of modulating the effect of matrix enzymes responsible for the migration of inflammatory agents through the blood-brain barrier. Methylprednisone is an example of a corticosteroid used in MS treatment. It is delivered intravenously at a daily dose of 200 milligrams for the first week initially, then 80 milligrams every other day for the first month after the first week. Adverse effects include drug hypersensitivity, vertigo, muscular weakness, and impaired hearing. Relevant assessments include general vital sign observations and physical assessment.
Medical management and nursing care for MS is provided by a multidisciplinary team. Each member holds vital expertise necessary to create individual ever-changing treatment plans and achieve the integrated approach required for long-term care. The collaborative effort with the patient at the centre is critical at all stages of disease management in order to minimise impact, maximise quality of life, support well-being and encourage self-care. Actions and activities are therefore focused on the self-awareness and self-responsibility of the patient, their families and or carers. We will look at 4 key areas of management and care. Area 1 is initial and ongoing information and education. Receiving a diagnosis of MS is life-changing for the individual and their extended support network. The initial amount of information can be overwhelming and understandably lead to feelings of anxiety or negative thinking. Delivery of clear and relevant information helps to manage emotions and thoughts as well as form a strong therapeutic relationship. This bond is influential in increasing understanding and knowledge of the disease, awareness when monitoring symptoms and progressions over time, encouraging compliance to treatment plans, and ensuring empowerment and autonomy through shared decision-making. Information should be holistic in nature, including what MS is, different treatment options, requirements of changes or choices related to altered lifestyles, options for continuation of care and support, navigating the allied healthcare services, physical activity, annual symptom management and rehabilitation. There are numerous symptoms that can afflict persons with MS. Some symptoms are relatively easily treated, others more difficult to manage. Management needs to be comprehensive and take the long-term view. Prescription of different disease-modifying therapies and medications will be used in conjunction with non-pharmacological treatments to manage and lessen symptoms and their consequences. Rehabilitation is important in the preservation of physical, psychological and social functioning, as many patients will have MS for more than 35 years. Interventions such as physiotherapy, cognitive behavioural therapy and exercise may be used. These must take into account current medical condition to determine which intervention is best suited to restore health and prevent further impairment. And finally, promotion of wellness and self-care for the patient, family and care providers. Although pharmaceutical remedies are generally the focus of disease management, they are not the only way to manage MS. A combination of rest and physical activity is an integral part of good health, wellness and quality of life, and is an area in which nursing can strongly influence the patient experience. Sustaining care requires continuous evaluation of physical, cognitive and emotional status. Changes should be assessed and treated when they become evident and when they interfere with activities of daily living. Self-caring abilities and treatment outcomes should be monitored to determine adherence to the plan and need to initiate strategies to improve. Nurses help patients and families cope with major responsibilities of managing symptoms and complications while maintaining normal lives and dealing with ordinary events and experiences of living.